So this is a talk about COPD and critical care. So I'm well aware that most of you know much more about COPD than I do, but there's a good reason for going over some of the basics, and that is because there are nuggets in there which are critical when it comes to intensive care management. So the overview of what I'm going to talk about includes what is COPD, the treatment of COPD, who should be admitted to a critical care unit, and then thoughts on non-invasive ventilation, invasive ventilation, the importance of cardiac dysfunction in COPD, and something about the future. And obviously I won't be offended if you want to skip ahead through some bits that are clearly too straightforward for you. So if we look first of all at what is COPD, have a look at the slide. Which of the four people there is most likely to have COPD? And think about why you're answering as you are. If we look at the ATS and ERS definitions of COPD, it's a preventable and treatable disease state characterised by airflow limitation that's not fully reversible. The important bit to my eyes is that it's associated with an abnormal inflammatory response of the lungs. Although COPD affects the lungs, it also produces significant systemic effects. And you knew that inherently, and you knew that looking at the previous picture, where you chose the guy who not only was using oxygen long term, but also was wearing a jumper that was 2 sizes too big for him, and got a general appearance of sarcopenia over the people who were suffering from heart failure, and the one who, to my understanding, is perfectly fit and well. So I like this quite a lot. This is from the British Lung Foundation, and it's their patient-facing website. This is the information patients should understand. There's actually some truth here that we do well to take on board. 1, this is a chronic condition. The patient had the condition yesterday, they had it last week. If they're now presenting for a possible ICU admission, what is it that's changed? It's obstructive. Expiration and hence ventilation is the primary problem. And there is no cure. Patients should be aware of this, and they may have already considered advanced planning. I'm not going to dwell too long on the grading of COPD severity. You'll be very familiar with this. But I do want to have a quick look at end-stage COPD. This is defined by a severe airflow limitation with an FEV1 less than 30% predicted, a performance status that's severely limited and declining, and other criteria including advanced aged and advanced systemic manifestations and complications, pulmonary hypertension, cardiac impairment and fluid retention. And it's important that we're honest with both ourselves and with patients when we identify end-stage COPD. If we look at the components of COPD, again this will be very familiar to you. Chronic bronchitis, you should look for the presence of chronic or recurrent increase in bronchial secretions sufficient to cause expectoration, present on most days for a minimum of 3 months. An emphysema, defined anatomically by permanent destructive enlargement of air spaces distal to the terminal bronchioles, without obvious fibrosis. I'm not talking here about CPFE, but you'll be aware of that. And chronic asthma in small print. You'll be aware too of the risk factors for COPD, mostly tobacco smoke in the Western world, air pollution, indoor pollutants, including particulates and carbon monoxide, and females exposed to biomass smoke, particularly in the East, where installing chimneys in stoves in China led to a dramatic reduction in COPD incidence. Again, a reminder, this is the effect on a ban on the sale of coal in Dublin, where black dots are winter deaths, and the ban is the dotted line vertically. This is COPD in a 30-year-old male, and a reminder to not forget about asking about other inhaled substances beyond tobacco. And of course, we have yet to gather sufficient evidence to talk about the effects of vaping. So we're asked to suspect a diagnosis of COPD in people over 35 who have risk factors, generally a history of smoking and one or more of exertional breathlessness, chronic cough, regular sputum production, frequent bronchitis, whatever they mean by that, and wheeze. Recall that it's always worth asking about the following, particularly red flag symptoms such as chest pain and hemoptysis, which are rare in COPD and raise the possibility of other diagnoses. Recall that COPD and asthma are relatively easily teased apart. The variable breathlessness in asthma and the uncommon night waking and uncommon variation in COPD being the key factors. Recall also that exertional breathlessness needs to be contextualised, and so we're given the MRC breathlessness scale. Remember that if you're looking at a patient who is a smoker, then it's not just COPD that they're prone to, and there's a whole panoply of chronic diseases which might be coexisting. You know full well the treatment for COPD, primarily smoking cessation and pulmonary rehabilitation, with some role for inhaled therapy below that. The role of oxygen therapy for those who have a PO2 less than 7.3, or those that have a PO2 of greater than 7.3 when stable but with signs of secondary polycythemia or pulmonary hypertension or edema. And so we go from there to consider who is it that should be considered for admission to critical care. And actually, the question of who to admit to a critical care unit is perhaps confused further by the varying definition of what is a critical care unit. So what I'm going to do is I'm going to focus on some treatment modalities for COPD. Where they are offered or conducted well varies between hospitals. If, for example, you think of NIV, then not everyone on NIV needs an arterial line, but it is perhaps kind. Sometimes it's performed in a dedicated bay on a ward, sometimes within a medical HDU, and sometimes on a critical care unit. Think about the geography of where the patient is being treated and whether you would escalate to mechanical ventilation. And that might define for you when a patient should be moved to an area of higher care. But the correlation with research is very difficult, partly because of this moving definition of a critical care unit, and partly because of the moving definition of the treatment modalities that are being provided. If if you think about the reasons to consider critical care in COPD patients, I would list them as following: acute exacerbation of COPD, pneumonia, iatrogenic, whatever that might look like, and possibly that looks like oxygen toxicity, and I'll talk about that more in a moment. Another problem to which the COPD is coincident. The reason not to admit a COPD patient to critical care is because they're dying. And as with the diagnosis of end-stage COPD, I think we need to be honest with ourselves and with the patients when we've identified that state. Defining an acute exacerbation of COPD. It's defined as an acute worsening of the respiratory symptoms over a few days requiring a change in treatment. Triggers include bacterial infection, viral infection, inhaling irritants such as smoking or passive smoking, changes in weather, and changes in psychological or emotional stress. Pneumonia is defined as bacterial, viral or fungal infection, and I accept that Puritans will demand chest x-ray changes that go alongside that. Looking at iatrogenic problems and oxygen toxicity, it's beat into us from the very first days of FY1 that you should never give too much oxygen to a COPD patient. The story told is that they rely on CO2 drive, and that you're reducing that with oxygen and leading to a reduction in their minute ventilation. However, that's only partly true. Oxygen therapy does have some effect on reducing minute ventilation, but it has a much bigger effect on reducing hypoxic pulmonary vasoconstriction and worsening VQ mismatch. Gold standard practice is that when the patient arrives at hospital, an ABG should be measured and the inspired oxygen concentration noted in all patients with exacerbations of COPD. Measurements should be repeated regularly according to the response to treatment. Thinking now about non-invasive ventilation. Looking at the indications for NIV, in patients with mild exacerbations which are not complicated by acidosis, there is no improvement in hospital stay or mortality, and tolerance is less than 50%. Where the pH is less than 7.25, the rate of NIV failure is inversely proportional to the severity of the acidosis and is about 50 to 60%. In patients with mild to moderate acute respiratory failure, characterised by pH levels between 7.25 and 7.35, tolerance to NIV is good. Contraindications to non-invasive ventilation. Well, cardiac or respiratory arrest, severe encephalopathy, severe gastrointestinal bleeding, severe hemodynamic instability with or without angina, facial surgery or trauma, upper airway obstruction, the inability to protect the airway and or high risk of aspiration, and the inability to clear secretions. It's clear that NIV works in acute exacerbations of COPD. It improves the pH, CO2 and respiratory rate in the first hour. It decreases the incidence of intubation. It decreases complications and it decreases mortality. It has a relatively low NNT of numbers needed to treat of 10. So here's a number of studies, probably all too small to read, but you can see that the general trend is towards improvements in the rate of intubation and improvements in the mortality. It's actually equally valid when analysed by severity. The rate of intubation, odds ratio of 0.5 when the pH is over 7.3, and an odds ratio of 0.4 when it's less than 7.3. And again, fairly similar numbers for mortality as well. What about what happens when patients get sicker? Well, this does have to be seen in the context of the authors. Squadrioni comes from an enthusiastic Italian institution familiar with using NIV. Admittedly, also these papers are starting to get somewhat old. But 64 patients with acute exacerbation of COPD with an admission pH less than 7.25. They were matched with historical controls who received mechanical ventilation. You can see that mortality was improved in the NIV group over the mechanically ventilated group. You can also see that in those where NIV was successful, they got themselves off ventilation much quicker than those where NIV failed, or those who were initially put into the mechanical ventilation arm. So in successful NIV, serious complications were reduced, ICU mortality was improved, and that although there was no difference post-ICU mortality, the number of ventilator days was reduced, the ICU length of stay was reduced, as was the hospital length of stay. But NIV failed in 40 of the 64 patients and they required intubation. And as I said earlier, this was all done in the context of an ICU, not a ward-based or medical HDU-based setup. What happens if you look at even sicker patients? This group, I think they're a Mexican group, looked at patients with hypercapnic respiratory failure and a GCS less than 8. 80% of the patients responded versus 70% where the GCS was greater than 8. There was no difference in mortality. An improvement in GCS in the first hour predicted outcome. So perhaps unconsciousness is not actually a contraindication to NIV. I'll come on to now talk about invasive ventilation. Asking the question, who should we escalate to mechanical ventilation? NICE indicates the role in acute exacerbations of COPD following failure to respond to NIV. But the statement highlighted that identifying patients that would benefit from mechanical ventilation is difficult and involves balancing health status with an estimate of expectation of survival. Looking at the BTS and SIGN guideline on NIV in COPD, again does not specify to whom escalation to mechanical ventilation should be offered. Mechanical ventilation may be withheld in acute exacerbations of COPD on the assumption that patients would have a protracted weaning process, a subsequent poor prognosis, or an unacceptable quality of life after hospital discharge. It's also true that resource rationing has contributed to setting NIV as a ceiling of care. Clinicians' decision to instigate mechanical ventilation vary considerably. This was highlighted by the Wildman group in Sheffield. They looked at variation in intubation decisions for patients with COPD in one critical care network. So we're looking at local study. Here are 3 different cases. figures 1, 2 and 3. To the right of each figure is the predicted survival from the support trial. So in figure 1, predicted survival is 74% for 180 days. In the second case, 84%, and in the third case, 34%. And then along this is physicians' predicted outcomes. So divided in each case into those critical care clinicians who would admit the patient, and against those on the right are clinicians who would not admit the patient. So you can see that there is a wild variation in predicted survival. So ICU survival, for example, in figure 1 varies from 60% down to 10%. Likewise in figure 2, the survival varies, the ICU survival varies from 50% down to 15%, and so forth. So we can see that when it comes to estimating prognosis, physicians have wide-ranging opinions in the same patient scenario. Specifically, there is a tendency for them to be more pessimistic than optimistic. If we look at factors affecting hospital mortality in COPD, a protracted length of hospital stay prior to ICU admission is an adverse prognostic factor. The odds for hospital mortality increase by 2% for each day in hospital. The presence of multi-organ failure and the coexistence of sepsis is an adverse prognostic factor. Acutely deranged PaCO2 and PaO2 are not useful in determining outcome. Acute exacerbation of COPD without radiological change in the absence of cardiac failure, pneumonia and ARDS have better outcomes. Further factors predicting mortality. Pre-exacerbation FEV1 has a limited value in predicting outcome in the acute setting. The presence of untreated pulmonary hypertension due to chronic hypoxemia is an adverse prognostic factor, but the use of LTOT does not predict acute outcome. Chronic hypercapnia and the requirement for home ventilation does not necessarily predict poor outcome. Previous mechanical ventilation for acute exacerbation of COPD does not appear to be an adverse prognostic factor. Looking at the effect of age, nutrition and comorbidity, age is not a reliable independent predictor of survival for COPD patients being mechanically ventilated. Body composition and nutritional status are independent predictors. A BMI less than 20 and an albumin less than 30 are shown to be associated with poor outcomes. BMI is also associated with the FEV1, the 6-minute walk distance, the length of stay and readmission rate. The presence of comorbidities such as cardiovascular disease and diabetes are negative prognostic indicators, as you might expect. Taking things further, the Wildman Group, again in association with Kathy Rowan, who runs the ICNARC database, produced predicting mortality for patients with exacerbations of COPD and asthma in the COPD and asthma outcome study, or the CHAOS study as it was known. I'm in no way expecting you to absorb or learn this slide, but there are some interesting points to be taken from it. essentially the higher your score, the worse your outcome. And we can see that factors that look to be important are male sex, which carries greater risk, your physical function 2 weeks before hospital admission, and the presence of atrial fibrillation, which might come as something of a surprise, and we'll think about that more in due course. And then there are other factors such as days since hospital admission, mid-arm circumference as a measure of nutritional state, and the COPD acute physiology score. The COPD acute physiology score is further broken down into these factors. So measurements of cardiovascular fitness, of renal function, and of coexistent infection. So it's difficult. It's difficult to know which patients should be brought to intensive care. The decision involves balancing the health status of the patient with the expectation of survival, and it's often made somewhat pragmatically with scant information. Occasionally it's in the face of unreasonable expectations, and unfortunately for good or worse reasons it often occurs out of hours. In patients who are admitted to critical care, there are some strong predictors for poor outcome. Comorbidity, the need for mechanical ventilation beyond 72 hours, and failure to thrive following extubation from mechanical ventilation are all significant. There are also cultural differences to be recognised. In the UK, withdrawal of treatment was the most common cause of death among COPD patients on critical care. Compare this with Italy, where 2/3 of patients were found to still be actively weaned 60 days after admission. The need for mechanical ventilation. In most cases, it is failure to improve with medical treatment in the hours following admission that triggers a critical care admission and the request or the consideration for mechanical ventilation. Late failure is less common and indicates a worse prognosis. Having a think about the mechanisms involved in decompensated COPD, I find the rather simple analogy of a bloke carrying a box to be helpful. Reasons to fail in your task of carrying the box may be because the box is too heavy, because the muscles required to carry the box are too weak, or because you simply lack the motivation to carry out the task. So increased resistive load results from widespread airflow obstruction. Compliance of the lungs falls as they operate from higher volumes. Dynamic hyperinflation occurs as expiratory time is shortened and there's poor emptying of lung units. The reduced power of the respiratory pump comes about as efficiency is impaired and acidosis and hypoxemia take hold. And both sleep deprivation and CO2 narcosis can result in impaired drive. Looking at dynamic hyperinflation and the inability of the lungs to empty properly, consider increasing the expiratory time during mechanical ventilation to allow true airway emptying. Intrinsic PEEP is also elevated in COPD, and application of extrinsic PEEP will increase tidal volume with no change in the maximum pressures, until extrinsic PEEP exceeds the intrinsic PEEP. Think also about ARDS and the ventilatory criteria set out. Permissive hypercapnia is entirely reasonable. It is entirely appropriate to accept hypoxia in mechanical ventilation of patients with COPD. Bronchoscopy has a clearer role than it does in asthma exacerbation, removing respiratory secretions. Of course, this does need to be balanced with de-recruitment of the patient off the ventilator. And recall that the role of steroids is over days, not hours, and it should not be seen as an elixir. I'd now like to have a think about cardiac dysfunction during COPD exacerbations. Diagnosed cardiac comorbidities are common in patients with COPD. They're associated with a worse outlook. And COPD exacerbations are often complicated by acute cardiac dysfunction. And it's often possible to note biochemical evidence of myocardial stretch and myocardial injury in patients with COPD exacerbations. This slide shows a potential pathway through which acute exacerbation of COPD can lead to acute cardiac dysfunction. I've described the right ventricle as the forgotten ventricle. COPD exacerbations are associated with acute increases in pulmonary artery pressure. Raised pulmonary artery pressure in patients with stable COPD is associated with poor left ventricular diastolic function. As well as this, poor right heart function is associated with impaired left heart function in patients with COPD. I think it's perhaps for this reason that the Wildman study found such a strong signal for atrial fibrillation, leading to poor outcomes in acute exacerbation of COPD patients taken to intensive care. And this slide describes the cycle of RV decompensation. And for those who like echocardiogram, here's some pictures to remind us what's going on in a graphical format. So RV failure can result from excessive preload, from excessive afterload, or through insufficient contractility. When looking to manage RV preload, proper fluid management is critical. In the context of the raised pulmonary vascular resistance which we see in COPD patients, we're normally looking to reduce end diastolic pressures. This is traditionally brought about through diuresis. And it's important to note that the right ventricle has a flatter Starling curve than the left ventricle, so it may need quite significant amounts of fluid removal before we see any improvement in cardiac output. When it comes to the management of right ventricular afterload, excessive afterload plays some part in nearly all causes of acute right ventricular failure. Hypoxic pulmonary vasoconstriction is key. We should look to correct hypercapnia, acidemia and alveolar hypoxia. Sometimes this can be at odds with the ARDS-NET criteria, and it's difficult to know where the truth lies. There's also a potential role for pulmonary vasodilators such as nitric oxide, sildenafil and iloprost. These are the currently available pulmonary vasodilators. There's no evidence available at present for their role in acute exacerbations of COPD. Looking at the management of insufficient contractility, there's a role for both vasopressors and inotropes, potentially a role for VA ECMO as well. Thinking towards the future of the management of COPD in the critical care setting. Well, I think that extracorporeal CO2 removal shows interesting promise. So this lady has got a passively driven CO2 filter just sat between her legs there. You can see that she's wearing nasal cannulae. She's got something approximating to a smile, and that her NIV mask is hanging unused to the side. A UK feasibility study is currently underway and has yet to report. Anecdotal feedback is that COPD patients love it. Hypercapnia is a big drive of dyspnea and tachypnea, and so the whole setup is much more comfortable for them. And many are reporting that 2 cannulas under local anaesthetic is better than a claustrophobic mask. There is already some evidence base. Looking at this paper in intensive care medicine, avoiding invasive mechanical ventilation by ECO2R in patients failing non-invasive ventilation. Here, 21 patients who'd failed NIV received a pumpless extracorporeal lung assist device. They were matched with 21 controls who did not. Of those 21, 2 required intubation, and 14 of the 21 had COPD. So, although the PECLA group might not show any reduction in 28-day mortality, they do show a significant reduction in intubation and in ICU and hospital length of stay. I think this is something that we're going to hear more of in the future. So I'm going to end it there, and I will happily take any questions that you have or any thoughts that you'd like to bring to the group. Thanks.